to this edition of Pulse on Health. I'm your host, Mark LeMay. This week's topic is the topic that's been on our minds for almost a year now, the COVID-19 virus and what's being done to help prevent the spread. Joining me on this edition of the program is Dr. Zandra Kelley, Chief Medical Officer of GLFHC, and personally, the second person I trust when it comes to COVID-related stuff. The first, Dr. Fauci. So you're in good company, Dr. Kelley. Welcome to the program.
Thank you so much. It's great to be
First
here.
off, what is COVID? How did it get its origin? How did it spread?
Yeah, so COVID is an illness that's caused by a virus called SARS-CoV-2. This virus is a member of the coronavirus family of viruses. So some viruses in the coronavirus family infect people all the time, and they cause what we know as the common cold. Viruses can also infect animals, and in this case, SARS-CoV-2 was first in animals and then was passed to humans. So it started to spread directly from human to human, mostly through air droplets that passed from person to person. And the virus also spread indirectly when a person would sneeze or cough on their hand or get some viral particles onto their hands, touch an object like a door handle. And then those particles get passed to the next person who touched the door handle. Another person can get the virus when they are coming and touching and then touch their face, which makes it get into their eyes, nose, or mouth. So that's why there was a lot of information about sanitizing, but also trying to not touch the eyes, nose, and mouth with your hands.
Is it possible a virus like COVID could begin here in the U.S.? Because this one apparently started in China.
Yes, so certainly it would be possible. However, in the US, we don't have the type of open market selling animals to the public, like was the case where SARS-CoV-2 passed from an animal to a person in China. We do have fairly strict ways of handling animals produced for food in the US. And so this method of transmission of a virus from an animal to a human is less likely, but it's not impossible. But it is always possible for viruses to mutate even in people and get passed from person to person. So think of, for example, the flu epidemics that we've had in the past. So the flu virus could mutate in a way as it's being replicated and passed from person to person that makes it much more likely to cause severe illness or much more likely to spread easily. And that's when we tend to see epidemics of flu in our environment.
And we're hearing that now with the UK variant of the COVID virus. And there are a couple of different variants.
Yep.
Explain that, please.
Right. So every time the virus enters someone's body, it replicates, it creates, thousands and millions of copies of itself. And as it does that, sometimes there are mistakes made in its replication process. And sometimes those mistakes actually create a virus that spreads more easily or that causes more severe disease. It creates plenty of viruses that do less well also, and we just don't see those because they don't get passed as easily. So the more the virus spreads, the more people get infected, the more the virus replicates, giving it a chance to actually create a virus that spreads more easily. So that's what we're seeing, because once the virus creates a version of itself that spreads more easily, then of course that's the one that gets spread from person to person. And so that's how we're seeing these variants come to play right now in the UK and now being passed all over the world, because this one spreads more easily. So it is becoming more dominant as the virus that's being passed from person to person.
Our guest is Dr. Zandra Kelley, Chief Medical Officer of Greater Lawrence Family Health Center. Let's get back to local. In the Merrimack Valley, in your opinion, were we quick on the response to COVID in the outset? And have the rules changed as the pandemic has changed?
Yeah, I would say that in general, especially given that we have not seen a pandemic like this in our lifetimes, we were pretty quick to respond as it was spreading very rapidly locally. As you remember, businesses were closed, people were advised to stay home. Our clinic itself converted all of our visits to telehealth visits, except for the very urgent visits that needed to be seen in person. So there were a couple of things, though, that I think slowed everybody down, as we remember, like with the availability of COVID tests. So we were not able to test people that we thought might have it, or as we learned later, there were lots of people who had it who didn't have any symptoms. So they were really able to spread it without us ever being able to know that they had it or didn't. So there were many other difficulties in our area, including that people needed to continue to work. So some businesses were still open. Everyone needs to put food on the table. So the virus spread quickly at those workplaces that could not be closed. And more, as we learned more and everyone got on board with the masking, distancing, and sanitizing, I think that transmission slowly we were able to improve. But even in the beginning, everyone was making masks. We didn't have enough. We didn't know what types of masks would actually work. So we definitely learned as we went, and the rules definitely kept changing over time.
I want to take a minute and talk about telehealth, telemedicine. That sort of happened, at least from the health center perspective, literally overnight.
Yes.
How has it affected the way you as a physician treat patients?
It's opened a lot of doors, actually. I think in the past, the convenience of the in-person visit was difficult for some people. They didn't have transportation. They may not have been able to get off work to make it on time to a visit. So it really opened the door to allowing us to have a chance to get in touch with our patients when otherwise it might have been difficult. I've been able to talk to people when they're on their break from work, for example, and some people would have otherwise had a very hard time getting in for an in-person visit. I think also we've been able to check in with people more regularly. Someone who may be having some difficulty, I can call them the next week. They don't actually have to leave their house, get in their car, come into the clinic. And obviously it really helped to decrease the spread of the coronavirus because now people can stay at home, talk on the phone and get their medical issue addressed without having to leave their house. Now, certainly there are some things that need to be addressed in person. And so when we determined that that was needed, someone could then come out, have a test done, pick up a medication, come in for a visit in person. But it really has opened the door to just a ability for people to get medical care from many different modalities and has really helped us to be there for our patients when they need us most, even if they can't physically come into the clinic.
How are patients taking to telemedicine?
I would say that many of them were so thankful that we were able to check in with them. For example, we have a system in place now where if someone has coronavirus and they're at high risk, we can have someone check in with them every day and see how's your breathing, how's your oxygen saturation at home. And we've been able to actually help people understand, okay, now is really the time to go to the hospital, or, nope, you're actually doing really well. Your oxygen saturation's good. You can stay at home. So that type of follow-up with patients has really been appreciated. Of course, many people still like seeing their clinicians face-to-face. So we're definitely hearing that as well, that some really prefer the in-person visit. And luckily now we're able to accommodate both again.
As an aside, we're all focused on COVID right now, and rightfully so. But normally, we'd be focused on the flu. How are those numbers this year, and are they lower because of COVID?
Yes, so we are seeing very little flu. And that is true across every clinic, every hospital that I've spoken to. So I think the are multiple reasons. One, lots of people got their flu vaccine this year, as it was highly recommended. So that was great. But also, people are masking and distancing. And when you mask and distance, you spread these viruses less. So that has definitely been a huge lesson for us, to be able to see that we could actually prevent the spread of lots of different types of viruses by taking these precautions, especially when someone is sick. The other thing I think that it really emphasizes for me is how contagious COVID is, because we're doing all this masking and distancing and everything, and COVID is still spreading. So we're seeing almost no flu, but we're still seeing a lot of coronavirus. So I think it definitely shows me how contagious this coronavirus is.
Our guest in this edition of Pulse on Health, Dr. Zandra Kelley, Chief Medical Officer of Greater Lawrence Family Health Center. We're going to take a quick break. We're going to come back. We're going to talk about vaccines, and we're going to talk about the toll that it's taken on our physicians. We'll be back right after this. Welcome back to Pulse on Health. I'm your host, Mark LeMay. Our guest in this edition, Dr. Zandra Kelley, Chief Medical Officer of Greater Lawrence Family Health Center. One of the things that I think gets kind of overshadowed is the frontline workers, the nurses, the MAs, the PSRs, and even the physicians. How are you doing?
Yeah, that's a great question, and thank you for asking it. I think, just thinking back to the very beginning, I think this was true of the entire population of the world, maybe. People were very scared. It's a new illness. People were getting very sick. And so those people who were coming in to care specifically for patients they knew had coronavirus, I think feared for themselves and their families, but they still came in. This is our job. This is what we do. And I think that it was definitely an extremely stressful time, unprecedented really, for most of us in our entire careers. I think another thing that was extremely difficult was that we were all isolated. Normally we get our we can sort of revitalize and get our energy back by having friends and family around and having some time to decompress. And that really wasn't able to happen during the COVID times, and still is very, very limited. And not only was that experience had personally by healthcare workers, as with everyone else, but they also watched their patients, especially those in the hospital, potentially dying completely by themselves, and tried everything they could, whether it was standing by the bedside and holding their hand, or getting a donated iPad or other device to let them see and speak to their family members in their last few moments. So that was a thing I think was the most difficult and terrifying and sad about this experience for healthcare workers, is that not only did they have their own isolation and decrease in the ability to recuperate as they normally would themselves, but they also watched these terrifying situations. And that's the thing I think that caused the most emotional stress and difficulty during this time.
Greater Lawrence is the host of the Lawrence Family Medicine Residency Program. Every year we graduate up to 10 docs in family medicine. But this year, the residents were on the front lines. They were handling the ER. They were handling the COVID unit at Lawrence General. Mm-hmm. How are they doing? Because, I mean, they're brand new. You're a veteran. You've been around the block a time or two. These docs didn't sign up for this, if I may put it that way. How are they doing?
I think it's definitely much more difficult, especially in training, to experience what I'll just say bluntly as so much death and so much illness. So that was definitely extremely stressful for the group of residents we currently have. There's also, like I said, isolation. They usually, they're young. They usually go out together. They socialize a lot, and um, as their supervisors or folks that were helping them through this period, they kept being coached to stay away from each other. Don't get together, don't eat together. And that's something that I think is extremely difficult to process any type of severe illness like this and experiencing death over and over. It's even worse to experience it when you can't decompress very well. You can't easily have those conversations that you would with others, or have ways of just recuperating a bit. So and my heart goes out to all of those people that were in training during this time, as it definitely is not what they were expecting or what they signed up for. And many of them are the frontline people. So they were the ones who really stood by the bedside, holding people's hands and trying to do their best to see what they could do with a virus that we really didn't have very many treatments for. So there wasn't a lot that they felt like they could do besides help them talk to their families, help with communication, and just be with them.
All right, let's talk about the big word, which is vaccines. They're now being rolled out to certain populations. How many vaccines are there, and are there any differences between them?
So right now, the emergency use approvals are only had by two vaccines. One is the Pfizer and one is the Moderna. So right now we only have those two. They are both mRNA vaccines. So they use the same technology to produce the vaccine, which is why they were the first ones to come online, because the mRNA vaccines are much easier to create and produce than the vaccines that we have produced in the past. So those two have some differences, but overall are pretty similar. They have differences in terms of their storage and the way they needed to be mixed, to be distributed. But those are pretty minor differences in terms of what people are actually seeing when they get the vaccine itself. One of the vaccines requires 3 weeks in between doses, the other one 2, but they both, the other one 4, but they both require 2 doses. So in that sense, they're pretty similar. There are other vaccines that are being developed right now that are not mRNA vaccines. So those, as they come out, we will learn more about their effectiveness and the differences between these vaccines we currently have and those that are coming. Some of the vaccines that are coming out may be only 1 dose instead of 2. But I think that the huge benefit of these 2 vaccines we have right now is that they are around 95% effective. That is really amazing for vaccines, actually.
And if I may editorialize for a second, it's not just amazing, the 95%, but it's also the timing in which we turn this around, because, and correct me if I'm wrong, but typically a vaccine takes like 12 to 18 months from start to finish. This took a couple of months, if I'm not correct.
Right, that's correct. And I think that part of it, again, is it's a new, I shouldn't say new technology, because it's been around for 10 to 20 years. Actually, there were vaccines developed for Ebola and for Zika, and they were mRNA vaccines, but they were never needed in this, breadth of population because those viruses started to decrease and spread on their own. So we never really needed to produce huge volumes of those vaccines. So mRNA vaccines have been around, but they are much faster to produce. And so that is where this turnaround time was fast. The other thing is there are many phases that vaccines need to go through. And because of the government support and funding that was available to these manufacturers, they were able to do many of the phases all at the same time because they didn't have to guess as to whether they would actually recoup all the money that they were putting forward to producing these vaccines. So they were able to do it very quickly.
We got about 4 minutes left. Let's talk about side effects real quick. Are there any? Do they vary from person to person?
Yeah, that's a great question. So there definitely are side effects. Like most vaccines, people usually get a bit of a sore arm after they have the vaccine placed, usually the next day mostly. And there are other symptoms that are related to the body's response, so the immune response to the vaccine. So that might include for some people just a mild headache. It might include a little bit of nausea. Some people with the second vaccine especially may get a fever. For people who have had coronavirus already, they actually may experience some of those symptoms a little bit more strongly than people who have never been exposed to the coronavirus. And that's really because the immune response has seen it before. And so it revs up, it builds its army even faster because it already has a little bit of experience with that. So that's where a lot of the symptoms come from. Actually, even when we get sick, when we get a virus, a lot of the symptoms that we get aren't caused by the virus itself. It's actually the immune system's response that is fighting off the virus that causes those symptoms. That's why we get those same symptoms when we get a vaccine.
Is there anyone, and this is going to, put you in an awkward position. Is there anyone that shouldn't get the vaccine?
So there are some people for which this vaccine is considered contraindicated or they should not get it. And it's mostly people who have had severe responses or reactions to either vaccine or other injected medications in the past. And that is likely not because of the actual mRNA component of the vaccine, but because of the other materials that get put into the vaccine vial that are required to help maintain the stability of the vaccine and to inject it properly. So there are some components of the vaccine that are used in developing other injected medications and other vaccines. And so if anyone has had a reaction in the past to that type of injected medication, they may have a similar response when they get the COVID vaccine because there may be a material that's similar in the COVID vaccine. But usually we only say if they've had a very severe response to a prior injection, which usually we just use the term anaphylaxis, which means somebody has, swelling of their face, their throat, trouble breathing, the kinds of things that if people are familiar with an EpiPen, which many people are because there are all these peanut allergies and other things around, the kinds of things that an EpiPen would resolve. So, even people who have anaphylaxis, the resolution is usually pretty quick with the EpiPen. But it is recommended that people who have had anaphylaxis before do not get the vaccine.
Real quick, last question. Are we ever going to see a time when we're not going to have to wear face masks? And what about getting back to normal?
Yeah, I wish I could say yes, there will be that time. My guess is that we will evolve a bit more into just sort of a different way of preventing spread of illnesses, as we have learned so much that the masking and distancing and things like that work. We may become more similar to how some other countries manage illness, such as actually not having people go to work when they feel sick and actually having it be normal for people to wear a mask if they are coughing or sneezing or are ill. So those are some things that some other cultures actually already do because they think, they know that it decreases the spread. And I think those cultures also adjusted much more quickly to decreasing spread of COVID because they already had that, sort of sense of masking and distancing and staying home if they were feeling ill. So some of those things may remain, but hopefully a lot of the other things will be able to go back to normal.
I got to tell you, I'm just looking forward to being able to go out to eat one night.
Yes.
Without having to worry about distancing and masks and hand sanitizing and all this other stuff. And it's certainly taught me a few lessons, I'm sure many others as well, about germs and spreading and being contagious and what have you. So maybe this is Mother Nature's way of kind of giving us a dope slap, I guess. Dr. Zandra Kelley,
I think we've all learned so much.
Thank you so much for joining us on this edition of Pulse on Health. Until next time, I'm Mark LeMay. Have a great week.